much better off than we are today.
Right.
So since we are already starting some discussion here, and I know we have a little over 200 of our attendees already on with us, I'm going to open it up. I am Dean Jessica Berg, and it is my pleasure to welcome you to this panel that's going to be discussing the 2020 election and the future of healthcare here in the United States. I'm going to turn it over for more specific panelist introductions before I kind of hide back in with the rest of the attendees to listen to the very interesting debate here to Professor Max Mehlman. He is a distinguished university professor and the Arthur E. Petersilge Professor of Law and co-director of our Law Medicine Center. So welcome everybody, and Professor Mehlman, I'll give it over to you.
Thank you, Jessica. Good afternoon, everyone, or morning. Welcome to our webinar. I am one of your moderators. My co-moderator is Sharona Hoffman, who is the Edgar A. Hahn Professor of Law, co-director of the Law Medicine Center at Case Western Reserve University School of Law, professor of bioethics at the CWRU School of Medicine. Joining us today are Joe White, Luxembourg Family Professor of Public Policy in the Department of Political Science at Case Western Reserve University, Jessie Hill, Judge Ben C. Green Professor of Law and Associate Dean for Research and Faculty Development at Case Western Reserve University, Sara Rosenbaum, Harold and Jane Hirsch Professor of Health Law and Policy and founding chair of the Department of Health Policy at George Washington University's Milken Institute School of Public Health, and J.B. Silvers, John R. Mannix, Medical Mutual of Ohio Professor of Healthcare Finance and Professor of Banking and Finance at the Case Western Reserve University Weatherhead School of Management and the Case Western Reserve University School of Medicine. Professor Hoffman and I will begin with brief overviews of the candidates' healthcare platforms. Each of the other presenters will then speak briefly about their perspective on the candidates' plans. And then we will open it up for questions from the audience. To ask a question, please go to the Q&A tab and type your question. There are almost 500 people participating, so we apologize that we will not be able to get to all of your questions. Professor Hoffman?
Thank you so much, Professor Mehlman. Just a word about CLE. I will be putting the CLE slide up towards the end of the presentation. You also should have gotten a link to the evaluation form that you need, and I will place that in the chat as well as a reminder. So that is if you need continuing legal education credits. And now I will share my screen and hopefully bring up a slide which is all about Biden's plan as far as we know it. So, what does Biden say he wants to do in terms of healthcare reform? Well, he wants to retain and strengthen the Affordable Care Act and create a new public option. Public option was discussed in the Obamacare era, but was eventually abandoned because of too much opposition. He wants to increase the number of people eligible for the Affordable Care Act subsidies and enhance those subsidies. He wants to retain the ACA Medicaid expansion. He wants to provide an option to enroll in Medicare at age 60 rather than at age 65, which is what it is right now. He wants to increase health insurance coverage options for immigrants, reduce prescription drug costs, which actually Trump also doing for long-term care, which is a huge problem because regular insurance does not pay for nursing homes, assisted living, in-home care, and this is increasingly a problem as the population ages. And finally, he wants to restore and expand reproductive rights, and we are going to hear more about reproductive rights from Professor Jessie Hill in a little while. I think that's all I'll say about the Biden plan. So Professor Mehlman, your turn.
Okay, let me share my screen. Can you all see my slide now? Okay, thank you, Professor Hoffman. So President Trump has indicated his support for the following. First of all, lowering Medicare drug prices, both for Part B drugs and Part D. For example, a proposed $200 drug discount card to be sent to Medicare beneficiaries. Permitting the importation of prescription drugs on the theory that they'll be cheaper if they're purchased in other countries. Requiring greater disclosure of healthcare prices by hospitals and drug companies, although litigation has interfered with that plan. An executive order last week ordering Congress or the Department of Health and Human Services to protect patients against surprise billing. Repealing the Affordable Care Act. A declaration last week to protect patients with pre-existing conditions. Also increasing access to short-term plans that can exclude pre-existing conditions. So a little bit of dissonance there. Eliminating ACA provisions in the Affordable Care Act that were designed to curb insurer cherry picking. So to give insurers less incentive to try to only enroll healthier, less costly enrollees. Cutting funding for the Affordable Care Act's consumer enrollment and assistance, and also shortening the enrollment periods for the Affordable Care Act. Supporting allowing states to elect block grants for Medicaid instead of the federal sharing formula system. Limiting reproductive rights, which we'll hear more about. Limiting LGBTQ protections against discrimination. Supporting the repeal that happened already of the individual mandate in the Affordable Care Act, and also supporting work requirements for people under Medicaid. So that's a summary of President Trump's healthcare agenda. And we'll now turn to Professor J.B. Silvers.
Thanks, Max. I don't know whether we're going to go back to the regular screen or not, but it's interesting to note on your last slide that Trump's list is longer than Biden's, which is interesting since most people think that Trump hasn't done that much. But let me try to provide a contrast between these two in 5 different areas, 5 different areas where I think the key assumptions differ in important ways, having to do with the role of the federal government, private markets, the amount of coverage, cost, and how to deal with crises. In each one of those, there's substantial differences, and I think that's what reveals what's different between the two. In terms of the federal government, you can tell from the list that we've seen, Biden is clearly much more aggressive in terms of setting minimum conditions, which the ACA does, subsidizing and supporting the ACA, actions primarily around the Affordable Care Act. Trump, on the other hand, is trying to maximize choice and flexibility, both at the individual level and at the state level. Those reflect some values, I think, that are important to understand where they're coming from. Private markets is another place where they differ. Biden is effectively still using the framing of the ACA around managed competition, or at least that's what we used to call it, with significant federal financing and then some antitrust oversight. So again, there's some role of the federal government, some role of private markets, but the Trump people clearly expect the private markets to do almost everything. With tax deductions as a form of subsidy, negotiations, price information, ways to, in their view, make the market work better. I think those are critical, two critical views that are different. In terms of coverage, pretty clearly Biden wants to expand coverage to everyone possible. That's where the immigrant thing comes from, expanding the Medicaid coverage to the rest of the states that aren't covered right now, and doing other things. So maximize coverage. Trump, on the other hand, has bought into the more conservative view of limiting coverage based on individual conditions, that is work responsibilities, things of that sort, and citizenship. So they're pretty clear about that, big differences. The fourth item is controlling cost. And here, I think there's maybe even there's a little bit of less difference, but it's interesting. Biden has mentioned limiting price increases, negotiating drug prices, since Medicare is not allowed to do that now. He would like to let that happen. But he's basically expecting to build on the framework of the Affordable Care Act and Medicare as we know it already. Not a whole lot in the cost containment side. On the other hand, Trump is expecting negotiated prices to make a difference. He's surprisingly taking on the drug companies in terms of trying to use reference prices often from other countries, allowing importation from Canada, basically importing regulation from other parts of the world and hoping that competition will hold prices down and hold costs down. The last one was responsibility for how you handle a crisis. And this is the one we're obviously in right now. Biden has been very critical that the federal government must lead and must use science and experts in a central way. And this is a place clearly where there's a major difference. Trump has turfed an awful lot of this to the states, as we all know, with some federal support, changing the cost sharing arrangements for Medicaid, a few other things of that sort. But the criteria has been mainly concerned about economic factors rather than healthcare factors. And so there's, again, a substantial difference between those two. Now, the reason why I picked these five is I think that to understand the positions, you need to understand the underlying levers that they're expecting to use. The ones we often talk about are prices and negotiation, taxes, financing mechanisms. Those are the kind of levers of change that the two parties expect to use, and they reveal something about their underlying assumptions about what will work best. And so I think by looking at these five categories, we can begin to get a little bit of a difference in the underlying philosophy, as opposed to just the bullet points that we can see. You need to see both sides, where they're coming from, as well as what they plan to do. I hope I've set it up for the other people too, in terms of some of these contrasts, because we're going to pick up some of the other aspects in the following people, I believe.
Thank you very much, JB. We now turn to Professor Sara Rosenbaum.
Thank you so much, Professor Mehlman, and it's great to be with you all virtually. Someday we'll get to be back together physically, and that would be very nice. But I want to just add my voice on what I think is just absolutely the core kitchen table issue for families, which of course Dr. Silver's flagged, and I think it's worth an additional look, which is the affordability of coverage. So of course we have a situation right now, and Reed Abelson actually had a very good story in the Times yesterday about this, and it's dominated reports for some months now. We just have an unprecedented loss of coverage going on. People who have lost their jobs, they've lost their insurance, small employers, of course, who have been particularly hit by all of this. We're already a fragile group of employers for purposes of insurance coverage, and they just can't afford this. This is, you know, it's sort of the acid test for why we set up a health insurance marketplace. And owing to some, what I consider to be original deficiencies in the Affordable Care Act, the marketplace is simply not doing what it needs to do. That's problem number one. Problem number two, of course, is a problem that was visited on all of us by the United States Supreme Court in the 2012 Sebelius decision, namely the effective transformation of the foundational Medicaid expansion for the poorest Americans into an option. And still, after all these years and innumerable studies showing the value of expanding Medicaid from every conceivable vantage point, we still have, I think, as of today, about 13 states that do not, and about 5 million people with no pathway coverage because they're too poor for the marketplace. President Trump essentially position on this issue is to worsen the problem through, of course, the challenge to the Affordable Care Act, which would eliminate the Medicaid expansion and the marketplaces and the subsidized coverage. He's also, in the near term, worsened the problem by refusing in the federal exchanges to open up what's called a special enrollment period for people who are losing their jobs. The current special enrollment period is for people who are losing their group coverage. But there are a lot of people who are losing their jobs who, for better or worse, decided not to get coverage when they might have, but now really need the coverage. And we can rant and rave all we want about the short-sightedness of not having coverage. But needless to say, this is in the middle of a pandemic. You don't punish people. You make the coverage accessible, as far as I'm concerned. Of course, he has this, as Professor Mehlman points out, this sort of meaningless declaration. He talks about price transparency and cheaper drugs. These are meaningless to people who can't afford the coverage. Drugs could be cheaper because your co-insurance or your co-payment comes down. Price transparency, I suppose, could help some people, but it only helps you if you have insurance and you're making choices, and what you're trying to do is avoid out-of-pocket cost sharing. You can't even begin to afford this stuff if you have no insurance to begin with, which is not acknowledged. Vice President Biden, by contrast, sort of takes on the issue of affordability head-on in two ways. One is he deals directly with the original problem of the Affordable Care Act by lowering the percentage of family income that would have to go toward the purchase of insurance in the exchange, bringing it down to 8.5%. I'd like to see it lower, but at least it comes down to 8.5% as opposed to where it is today, which is just about 10% of your income, which is unrealistic for people who need affordable coverage, but also increasing the size of the subsidies. And the Kaiser Family Foundation has a very good piece out. They posted it yesterday, giving you some math on just how much his subsidy restructuring would lower subsidy, would increase subsidy help. And the other thing he would do, which is something I've written about, and it seems to be, as far as I'm concerned, the only viable constitutional option, short of a total replacement system, is to let people who are locked out of their Medicaid programs enroll in a zero purchase premium through the exchange with enriched benefits and reduced cost sharing. States that don't want to continue their Medicaid expansion anymore could send their folks off to the zero purchase model instead and pay essentially a clawback to the federal government. It's one of those situations where we're kind of at a dead end. A full successor would take care of the problem, but if you want to keep Medicaid, you've got to concede that we have to build something as sort of an off-ramp in the states that just won't budge. So I will stop there.
Thank you very much, Professor Rosenbaum. Now we turn to Professor White.
And also just a quick reminder, please type your questions into the Q&A. We will get to them shortly.
Oh, first of all, thank you for the JB for the overall overview of principles, and Sara for the specific ideas about reform and difficulties. I want to first start by saying this election is not just of a president, it's also of a Congress, especially of a Senate. And it's of an administration, which in Trump's case seems very different from the things he says in a campaign. His administration is basically a Pence administration on these issues, on issues of budget and healthcare and so on, and therefore much less moderate than some of Trump's own statements. And I also want to point out that at the extreme, the health consequences of this election could include the violence after the election that I think a bunch of us are afraid could occur. Hopefully more important over the long run, we have to distinguish what does and does not require legislation and what can and cannot be accomplished administratively if not blocked in the courts or if allowed in the courts. If Trump wins and doesn't lose the Senate, and maybe even if he does, he seems likely to have even more scope to change policy administratively than he has had. He has been blocked a lot by the courts, but with the new Supreme Court justice, that would become, I think, significantly less likely. Other panelists can better talk about that, but it seems likely to me. And of course, the Affordable Care Act doesn't seem likely to survive in particular. Actually, even if Biden wins, the court ruling will be before something is done by the court about the courts. Though we should not be totally sure. It should be emphasized that the legal reasoning in the challenge to the ACA is so horribly flawed that there's a possibility that even extremely conservative justices won't accept it. At the same time, if Trump wins, he could only pass legislation if the House goes along. I don't think the Democrats are likely to lose the House, which might leave room for modest action on drug prices, say, except that most Republicans really object to that. And it's hard to see a majority leader, McConnell, going along. And Trump's administration seems to be staffed with people who are quite happy to let him make statements and draft executive orders that don't actually do anything, but who would stop or sabotage serious proposals on some of these issues. If Biden wins, he too will be able to change policy through administrative means. His Section 1115 waivers will be very different, but the Senate is crucial. First, because we don't know how McConnell would handle appointments, even if the Republicans control it, even by one vote. And second, because the court could be so significant. And if that's true, and possibly as a matter of principle, after the stuff the GOP has pulled, the court has to be expanded, which means the filibuster has to be abolished. I can think of compromises, but I'm skeptical. I'm not sure Biden can get the votes to expand the filibuster, even with a Democratic majority. But it seems highly likely that the about-to-be new court would block many of Biden's executive initiatives. And legislation would still be very difficult with the filibuster in place. A lot would come down to parliamentary rulings about what can and cannot be done through the budget reconciliation process. And that brings me to two final points. First, what most of health policy and politics is like will be shaped by budget policy and politics if Biden wins. And that politics will change dramatically if Biden wins the presidency, as the Republicans go back to posturing against Democrats, which will make the moderate to conservative Democrats in the Senate nervous. And that will be especially significant if the Democrats don't take the Senate, but it will matter even if they do. Second, as Drew Altman and others keep pointing out, and as I think is probably true even given the serious concerns that Sara has raised, the main issue for most voters is not expanding coverage to the uninsured. It's controlling the ballooning costs of both premiums and cost sharing for those who currently have insurance, mainly through their employers. That, of course, is why Trump talks about drug prices without seriously doing anything about it. If Biden could explain why his policies would be better on surprise bills and on drug prices and on unaffordable cost sharing tonight, that might even move a few votes, but I'm not expecting that.
All right, thank you very much, Professor White. Our final speaker is Professor Jessie Hill.
Thank you. I'm going to talk briefly about reproductive and sexual health and rights under Trump versus Biden. There are some high-profile issues here, like Roe v. Wade, most obviously. There's also many actions that Trump has taken, that presidents can take, that very much fly under the radar in terms of at least popular news coverage, because they're done sort of at the agency level in ways that are not notable or splashy, but have a big impact. And one thing I just want to note before I get into some of the details of what those actions are is to just echo what Joe White just said, that this is an area where courts and legislatures are very active, and so it's not always going to matter who the president is, or the president is going to have limited ability to act without those other actors backing them up. Okay, first, abortion. Well, one of Trump's biggest actions has been to appoint judges, and in particular 3 Supreme Court justices who are opposed to abortion rights, creating a 6-3 majority of anti-abortion justices on the Supreme Court, which probably means that Roe v. Wade's days are numbered. It is probably too late for a new president to do anything about this, for Biden to address this, short of some sort of court packing with the cooperation of the Senate. Or federal legislation, which is something we could talk about. Okay, Trump supports the Hyde Amendment, which prohibits the use of federal Medicaid funds for abortions, although it pays for childbirth. Biden is on record as opposing the Hyde Amendment. He previously supported it, but he now opposes that legislation, would support repealing it. Trump also supports and has expanded what's called the global gag rule that forbids US funds to go to international organizations abroad if those organizations, even with their own funds, support abortion rights, refer for abortion, or support legalization of abortion. Finally, the Trump administration, and Biden would oppose the global gag rule. And finally, the Trump administration has adopted a policy of obstructing immigrant teens who are in basically federal custody, US custody, from accessing abortion services. So immigrant teens who are in the Office of Refugee Resettlement custody have been blocked from accessing abortion. Okay, contraception. Well, first of all, repealing or having the Supreme Court strike down the Affordable Care Act would also strike down its mandate that employers cover contraceptives in their healthcare plans. So that would be a difference between Trump and Biden. The Trump administration has adopted a gag rule for family planning providers under the Title X program that says basically if you get these federal family planning funds, which are for low-income individuals, that if you're providing family planning services, you cannot provide abortion or refer for abortion. The Trump administration has also adopted a very broad religious exemption from employers under the Affordable Care Act. So those employers who have to cover contraception under the Affordable Care Act can opt out if they have religious or moral, in many cases, moral objections to doing so. That Trump administration rule was just upheld by the US Supreme Court, although actually litigation is continuing on other grounds and will probably end up before an increasingly conservative Supreme Court. Finally, the Trump administration has supported excluding Planned Parenthood and any abortion providers, but predominantly Planned Parenthood from Medicaid funding. In other words, Medicaid funds that are used for family planning services cannot go to abortion providers like Planned Parenthood. That's what he wants to happen. He's not been successful in doing so far. He has allowed some states to experiment with doing this, but that program, if it went forward, would be deeply problematic because there are not other providers who can fill the gap of an organization left by an organization like Planned Parenthood if it had to pull out of providing family planning altogether. And it could also destroy Planned Parenthood because Planned Parenthood gets about $500 million a year in Medicaid funds. That's it. I'll stop there. There's more, but I'll stop there.
I'm sure there is a lot more. Thank you very much, Professor Hill. We've received a number of excellent questions from our participants. So Professor Hoffman, would you like to pose the first?
Sure. So one question was, how are we going to afford an expansion of Medicare? In other words, allowing people to sign up at 60 rather than 65. Who wants to take that one on?
Well, if nobody else will, you're going to add some people. You're going to be taking some of them off of employer budgets. So maybe there's some way to get at employers, but basically you're going to somehow tax people to do it. There will probably be a premium. They will be less expensive than current Medicare beneficiaries because they're younger. I think on average. I think JB probably has thought through this one a little more thoroughly. But you save some money from employers not covering those people, and therefore not being subsidized through the tax code for those people. Medicare care for these people will be cheaper than when they're covered through their employers, because employers are paying in the range of twice as much per service to hospitals and other providers than Medicare is. So, there's a way to do it. There's a way to do it, but some of it's going to be new money.
Yeah, I think I agree. Joe, this is a tough one. Can you hear me now?
Yes.
Can't
Yes.
tell. Yeah. The financing for Medicare is already a major issue. The forecasts are that it'll be insolvent, that is the money going in versus out, will be switching over within 2 or 3 years. So we're going to be in a crisis on Medicare with the way it is right now. So if we add more to it, even though it's lower cost, those people are a little less expensive in the early years, below 65, there's a major issue. Plus, we got rid of some of the taxes that were supporting Medicare under some of the tax law changes. So we've got a real problem. There's no question taxes have to go up. We have to get more money in from someplace. The obvious place is payroll. That's been under attack by the Trump people. They don't like the idea of payroll taxes. So this will be a problem. And I think it'll be a major sticking point of this expansion.
Thank you very much. Any other thoughts on that question? If not, we can go to a second question. Actually, several people asked Joe Professor White to elaborate on what he regards as the powerful flaw in the ACA argument before the courts.
Well, we of course have 5 law professors here, but the argument as I understood it, as made by our colleague Jonathan Adler and Abby Gluck, among others, is that the basic argument originally was that the individual mandate was central to the logic of the legislation. Congress had decided that, therefore, if the individual mandate went away, then logically the whole law is implicated and the whole law should go away. I think that the argument then is that since Congress got rid of the individual mandate, essentially by zeroing it out, then the whole rest of the law should go away. The objection to that is, but wait a minute, Congress got rid of the individual mandate. Congress did not abolish the rest of the law. Congress has spoken. Congress has implicitly said that it no longer thinks the individual mandate is inherent to the law, is necessary to the law, because it zeroed out one of them and it didn't get rid of the other one. And so therefore, for the court to step in and, well, as some courts already have, and say that, well, Congress got rid of the individual mandate and didn't repeal the law, but that means it meant to repeal the law, it just didn't repeal the law, is sort of weird.
Well, the other thing, Joe, is that it turns out that the mandate wasn't really that important anyway. The mandate went away and the enrollment didn't change that much. Nothing like what my economist friends thought it was going to be. So I think that may be a piece of evidence that the court has to take into account. The original argument of the 3-legged stool probably is not accurate.
Well, I think that the reason is that if you are being subsidized, in other words, if you're below 400% of the federal poverty level, right, it's a really good subsidy. Right. And once people have insurance, they don't want to give it up. And the real effect of zeroing out the mandate is that the ACA has become sort of Medicaid plus. It is a means-tested program in practice for people in between the Medicaid level and the 400% of the federal poverty level income level. And there's not that many people above that, but for people below that, it's just a really good deal.
Well, and they're heavily clustered down at the bottom.
Sara, did you want to respond?
Yeah, all these points are great, and of course, not just to build on Joe's point. Not only is it Medicaid plus, but the bulk of the subsidized enrollees are really clustered at the bottom of that range because that's where the subsidy is the best. I was just going to point out that the as far as I'm concerned, the other fly in the ointment is that there's no such thing as a mandate in the legislation. There is a tax penalty. There is a tax penalty for not buying insurance, and it was originally set at one level, and Congress dropped the tax penalty to 0, but a penalty remains nonetheless. And so the whole premise, which is that somehow there was this mandate, the mandate went away, and now the law must fall. Congress, in fact, always made it a choice. There were more consequences to exercising one's choice prior to 2017, but it's always been the same structure from a constitutional perspective. It's a choice. And so there's sort of no there in the entire case. We shall see what they do with it.
If I could just add, I mean, right, a lot of people think that this is a terrible argument for why the ACA should be struck down, although, you know, it's really hard to know what the Supreme Court is going to do with it, honestly. I don't know for sure. I don't feel as confident, honestly, that the Supreme Court is definitely going to buy the argument. But, you know, several Republican judges have already bought the argument, so that could be a sign. But I also just want to note that, you know, this is something Congress could fix if Congress had the will to do so, or if there's a Democratic Senate and they get rid of the filibuster or whatever it might be. But there will be time after the case is argued, before it's decided, that Congress could pass legislation reinstituting the tax, or do it in adding what's called a severability clause. There are various ways that Congress could pass, like, very quickly, legislation that would make the whole problem go away.
Okay, so I'm going to ask the next question, which is about data breaches. So a questioner notes that we've had huge data breaches in the past few years. Has either candidate proposed to do something about data security and data breaches?
Sharona, you might be the one to answer that.
Well, I think Joe has an answer, then I can supplement.
No. I'm just thinking there's all sorts of issues about data here, but Sharona is more likely to know the answer to this than I am.
Yeah, I haven't really seen anything specific to data breaches from either candidate. I know the Trump administration issued rules recently that actually have to do with data sharing and data interoperability, or electronic health record interoperability, which is a huge issue, because while we're worried about breaches, we're also worried about the fact that people's medical records are fragmented, that they cannot be put together and shared in ways that would actually help treatment outcomes. And so there is a lot of effort along the lines of interoperability, and there are some new rules which I believe were suspended because of COVID-19, so they're not being implemented right away. But I don't know of anything about enhancing data security specifically.
It's not really a campaigning issue. And so that may be why it's not really getting addressed. And similarly, you know, somebody like me will think that there's all sorts of problems with the whole electronic health record world that need fixing. But again, that's not a sort of talk to the public issue, really.
Okay, let's move on to the next question. A questioner asks, what are the candidates' positions on the Part C of Medicare, the Medicare Advantage plans? And one questioner notes specifically that the limited number of options that may be available to them under Part C, but I wonder, what are the candidates' plans for that?
I wonder where that person is. There are a lot of options in most markets, I believe, right, JB?
Yeah, there are tons of that's been a very lucrative market for insurance companies, so that's not going to go away.
Yeah, I don't think there's been any proposal to rein it in. Not that makes it up at the level of a candidate's position. I mean, ultimately, there may be positions in a new administration about curbing Medicare Advantage costs or something like that. But I don't think there's anything that's risen to the level of the presidential broad platform that we're now dealing with.
I think it's important to remember that, again, once somebody's in office, particularly if it's Biden, then the likelihood that Part C plans are still taking advantage of the system just in different ways than they were 10 years ago. Now, what they're doing is they are overdiagnosing people in order to raise the risk adjustment they receive, and that therefore there are savings that could be found from addressing the semi-fraudulent behavior of the Part C plans, will come up. But it's a hard thing to campaign on, because if you're trying to make Part C plans less affordable, less profitable, you're also likely to be making them less affordable for the 1/3 of Medicare beneficiaries who now have them. The plan sponsors will say, well, that will mean we won't have as many benefits, and you'll have to be paying more for your cost sharing or for your drugs or whatever. And so it's a tough issue for the Democrats to campaign on, because on the one hand, it's legitimately a place to try to get money. On the other hand, even more than in 2008, we're talking about a whole bunch of people who are relying on the semi-fraudulent extra money that is being used to pay for extra benefits.
But I think this is a place where you could use some, you can come in and change the payment rates for Medicare Advantage plans, and that isn't going to be all that public. When I ran the insurance plan a number of years ago, we were being paid 95% of general Medicare for that. Now it's not true anymore. They're making more. And, that was a political decision to expand the coverage. So could you ratchet it back? Could you go after those risk adjustments? Could you do technical things like that? Yeah, absolutely. So I'd expect the Dems to be a little more aggressive on that maybe than the Republicans.
One of those things where the election will make a difference, but they're not campaigning on it.
No.
Yeah, no, you're not going to talk about all that. That's hidden.
Okay, thank you. Sharona, Professor Hoffman, do you want to ask a question?
Sure. So the next question is, if the ACA is struck down, what will change for the average healthcare consumer? Or has the structure of the healthcare financing system changed enough that many ACA-induced changes are now entrenched and will not be reversed?
So I'm happy to start us off. Essentially, what changes overnight is that about 12 million Medicaid beneficiaries lose their coverage because the funding to extend the coverage to allow all low-income adults to be covered comes through the Affordable Care Act, and the funding is so dramatic. It's 90 cents on every dollar, that there's not even the faintest hope, especially in the middle of a pandemic when states are going under, that a state would be able to maintain this. So that's number one. Number two, of course, the subsidies that we've been talking about that people secure when they enroll through marketplace plans are also creatures of the Affordable Care Act. So all of the financial supports to make coverage affordable go away. Now, there are other changes that indirectly, of course, make coverage not affordable, and they would go away. For example, protections against annual out-of-pocket cost sharing, changes for the sickest people around community rating, and of course the charging very, very high rates to people who are ill. I mean, these are they all go to affordability, but the direct hit is the loss of the direct financial subsidies that have made it possible to create a pathway to affordability for low-income people in the United States. And right now, we are particularly adept at creating millions of low-income people because of structural reasons, intensified by the pandemic.
Yeah, I think you'd have a race to the bottom to some extent, like we were having before the ACA. Insurance companies, you can see it already with the short-term plans. Insurance companies would start doing stripped-down policies because they're competing on price, because there's a price illusion. The uncompensated care would skyrocket for hospitals, and that has to be passed on at higher rates for commercial plans. I think you would see a lot of secondary effects on this, besides the obvious direct effect Sarah's talked about. This would be a major change. Has it been baked into the system? I think we've assumed some of it's baked in, but I'm not so sure that we continue this way. I think we'd have some major disruptions.
Yeah, I'd be surprised if we didn't have some significant disruptions. But it is important to understand that only 20 million people are getting their insurance through the ACA right now, and that's out of 330 million. So if the question is, what will the effects be on the median voter? The effects on the median voter would immediately be relatively small. I think the pre-existing conditions thing might matter. I think the median voter may have a kid who's 24 and doesn't have insurance any other way. But most of the effects on the median voter, on most people, would be fairly small.
But I would qualify what you're saying, Joe, in one important way. When we were in the throes of the repeal and replace fight over the summer of 2017, spring and summer of 2017, two phenomenal things happened. One was that it turns out that everybody knows somebody on Medicaid. And while we all know as law professors or public policy professors that many of the people on Medicaid have their Medicaid coverage through pathways other than the ACA expansion funding, most people didn't. And it turns out that everybody knew somebody on Medicaid, and the public outcry was tremendous. That's number one. And number two, the other thing that came out was that the average premium for the subsidized people would rise into the thousands and thousands of dollars, which shocked people. And the final thing is that when the 23 million number hit, when the House bill, when the CBO estimates, the Congressional Budget Office estimates came out around the House bill, the number, you're absolutely right, 23 million people, far less than the majority of the population. It was electrifying. And so I think that it's one thing to sort of sit as a, as a cool analyst and say, in the end, it may not be that big a population hit. I think the way these things play out in the real world for people is that these are astounding figures.
Yeah, but I want to emphasize two things about that. One is that's an argument about the politics if they were taking a vote on it, as opposed to what happens if the Supreme Court actually rules in a certain way.
But then then the politics will come up immediately as to whether they restore it.
Right, but if you have a Republican president and Senate, I'm not sure much happens. The other thing is, it's important to remember what was going on in 2017 was they weren't just trying to repeal the Affordable Care Act. They were also trying to cut the rest of Medicaid in fairly substantial ways. And so again, and that wasn't simply a matter of there being a confusion of people confusing the rest of Medicaid with the Medicaid expansion under the Affordable Care Act. They were trying to cut the rest of Medicaid. And that, again, that is where, all the people who say, hey, I might end up needing it for long-term care, or my mother needs it is using it for long-term care, or my aunt is using it for long-term care, come into play, but that's not the ACA Medicaid expansion.
So people won't differentiate. I think they can't.
I'm trying to get to a few more questions.
Yeah, we want to get to because we need to leave time for the CLE information. So let me interrupt. Apologies. Would someone like to describe or tell us more about how the public option under Biden would work? How would that happen, and what would it look like?
Silence.
Well, I mean, I think it would be more mechanically feasible than certainly what came out of the ACA as the quote unquote compromise, which was the cooperative plans. I mean, I think the idea is to have a federal plan, meaning federally overseen, federally developed plan that's administered probably by private insurers, much the way all public insurance ends up being administered by private insurers these days, that would be available through all marketplaces I think the trickier question than the functionality of it is, at what point would people have the choice to go into a public option? You know, do you make it possible, to the extent that people want to do so, to leave an employer plan to go to the public option? We went through this in a manner of speaking with the so-called dependent, the family glitch problem. You know, do we allow families to buy coverage for their minor dependents, their children, through the marketplace if their family coverage is not affordable? And the answer was a resounding no. And so I think the pathways to the public option are a bigger complication than could you see a nationwide publicly subsidized but privately administered plan being offered.
That's interesting. The pathways is a good question, Sarah. I've thought about it. If I were asked to do it, I'd probably pick the Medicaid, the plans that are already being offered by Medicaid,
Right.
the Molinas
Right.
and care sources.
Exactly, a Medicare, you know, Medicaid managed care plan.
Yeah,
And-
they're the lowest
right.
cost plans around. And
They're everywhere.
accessible.
Yeah.
It'd be easy to put them in there and they'd be competitive.
And
They
the
would-
basic health program is sort of like that.
Okay, so this might be for Professor Hill. If Trump remains in office, what's going to happen to LGBTQ rights?
So it's an interesting question, because the main, I guess, provision that people are talking about in this respect is something called Section 1557 of the ACA, which forbids discrimination by entities that receive federal funds and in the ACA marketplaces on various bases, including sex. And in 2016, before Obama left office, his administration interpreted that language forbidding discrimination on the basis of sex to include LGBTQ individuals. There was litigation over this. A court struck it down after, you know, in the succeeding years. And then the Trump administration came in and said, well, we're going to adopt a new rule that, or new interpretation of this that says that sex means sex and not, you know, sexual identity or sexual orientation. And so, in other words, lifting the protections for LGBTQ individuals in healthcare. However, if Trump wins again, I mean, we have this recent ruling. It was not about Section 1557, it was about Title VII, but a ruling out of the Supreme Court saying, no, when you see the word sex in a statute, that just sort of by logic and definition includes sexual orientation, sexual identity. So, you know, I don't know that, I think there is litigation actually brewing again around this. I don't know that it's made much progress yet, but it's possible again that this is kind of out of the administration's hands and the courts are going to decide it in favor of protecting LGBTQ rights.
Yes, and I want to thank all of the participants who sent in questions and apologize that we couldn't get to all of them. There's some excellent questions left hanging, and I'm sorry about that. Next time we'll spend a day doing this. And I also want to thank all of the panelists and my co-moderator, Professor Hoffman, for administrative support from Patty Harbold and Martin Raska. When will the video, this is being videotaped, Martin or Patty, when will the video be available for viewers? And will it only be available for those who registered?
I'm not sure they're there anymore.
Oh dear. Okay.
It will be available at some point.
Yes, it will be available certainly to the registrants and probably to the public. So once again, thank you, everybody. We live in interesting times, and thank you again for all of your participation.
Thank you.
Thank you.